So if we went in order, we would have been talking about, I think, decisional capacity today. But I think that when we talked about the first ethics exam, we said that the last topic that was covered on it would be ethics. Is that right? Ethics and genetics. Is that right? I think decisional capacity, informed consent, the ones that we still have to do, decisional capacity, informed consent, conflict of interests, I think important session, and I think ethics and genetics. Is that right? Anybody remember?
We have.
Right. Anyway, I think this is I guess what I'm getting at is I think this is going to be covered on exam 1. It'll be covered either on exam 1 or exam 2. But I think it's exam 1, okay? So the reason we're going to do ethics and genetics today, because Danica was kind enough to let me know that she has one of her friends in the area, Sarah Carroll, who is a genetic counselor up in Connecticut. And so I thought that rather than spending the whole time today me talking about the ethics of genetics, it would be more interesting and more relevant to you to actually hear from somebody who does this on a day in, day out basis clinically. So what I'm going to do is turn it over to Sarah. She'll introduce herself and she'll talk a little bit about what she does, and then we'll just play it by ear. All right? So, do you want
So my name is Sarah Carroll. I'm a cancer genetic counselor for Hartford Healthcare. I'm affiliated with Memorial Sloan Kettering up in New York City. I am from Naples, Florida, so I'm a native here. I went to Florida Gulf Coast University and then transferred to UCF, where I got my degree in microbiology, molecular sciences, and psychology. I then went on to University of South Carolina and got my master's degree specifically in genetic counseling. So genetics and ethics is something that I do day in, day out, breakfast, lunch, and dinner. At South Carolina, I was trained not just in cancer, but also prenatal, pediatrics, laboratory, etc. And then when I graduated, I chose to specialize into cancer genetics. So BRCA testing, Lynch syndrome, testing minors for FAP, talking about MEN, when to have genetic counseling and testing is my bread and butter. I really enjoy what I do. I was trained for 2 years to do this position, and it has a lot of its challenges, but it also has a lot of rewards to it. And what I want to help to cover today is some of the ethical challenges that we see. It's not something that can be explained easily in a 2-hour class. It's something that I had to study for a long time to understand. Why do we do what we do? What's the best for the patient? But when we're talking about genetics, it doesn't just affect your patient, it also affects the whole family. So where do we draw the line on what your duties are for your patient versus the patient's whole family? Do you guys have any questions or anything that I can help to address up front? All right.
This is not a very inquisitive class.
Very silent, like a lot of my other talks that I do. So just to give you a little background about what my day-to-day is I'm not a doctor, I'm not a nurse. People are like, do I call you Dr. Sarah? No, just call me Sarah, that's fine. That's what I've been going by from childhood, so that works too. But I work 9 to 5, Monday through Friday, and some days it's actually 7 to 7, but some days it's 9 to 5. And I help doctors to identify who is appropriate for genetic counseling and testing by attending tumor boards and tumor conferences. That's where the doctors get together and they have like a new diagnosis of breast cancer. And let's review the mammograms or the breast MRIs. And when they present the family history, I help to identify that person's appropriate for genetic counseling and testing. And how can we use that information for not just their family, but also for their medical management purposes. So I work very closely with numerous medical oncologists, surgeons, GYN providers, primary care, and as well as physician's assistants. So it's going to be helpful for you guys to develop a relationship with your prenatal, pediatric, or even cancer genetic counselor in your area. So the goal is to, when we see patients for genetics, is to identify who's appropriate and to better determine what's their medical outcome. So for example, and I'm going to speak heavily on cancer because that's what I've been focusing on for the last 5 years. If someone has no family history of breast cancer, then we're going to start mammograms at age 40, go every year, or at least that's what we do up in New England. I know that the task force has different guidelines on that. But colonoscopy at age 50. But if we identify that someone has an inherited predisposition to developing cancer, and their risk is not 10 to 12% for breast cancer, it's maybe 55 to 65% with a BRCA1 or BRCA2 mutation, then what we do for that person is much different. So we can start younger at age 25 and do mammograms and breast MRI screenings rather than waiting until age 40 or missing the screening opportunity if that person develops cancer, which could have been either prevented or had earlier detection. So one of the goals that we have is early detection, identifying who is appropriate for increased screening, who may not need extra screening above and beyond the general population. So one of the things that Dr. wanted me to present was to share who might be appropriate to see a genetic counselor. And in cancer, there's ovarian cancer is a lot less common than when you hear breast cancer or colon cancer. In fact, I know that it's Pinktober or October's Breast Cancer Awareness Month, but for every 10 women that are with breast cancer, there's only one woman who's had ovarian cancer. And breast cancer has about a 5% likelihood of having a genetic predisposition to it, but ovarian cancer has a 10 to 30% likelihood of having a genetic predisposition. So up in New England, we recommend genetic testing for anybody that's had ovarian cancer. But to get into the ethics, and I don't have the slides. I have the slides here, but they're not my own slides, so I apologize. But when we have a case of in clinical practice, I have a 31-year-old man who had colon cancer, and he had presented with rectal bleeding. And his family history, his father had died of colon cancer at age 40, so he should have started 10 years prior at 30, but he had delayed going for that. Well, we did screening on his tumor called immunohistochemistry for mismatch repair deficiency, and that's a pretty routine test that's done on all colon tumors to screen it to see if it has any genetic deficiencies. Why we do that screening is because that if it's a stage 2 colon cancer, it can help us to determine who might better benefit from certain chemotherapies and who may not benefit from chemotherapies. So that's the major reason why we use that tumor test. But the side effect from that testing is that it can tell us who has, rather than a 5% chance of having a colon cancer gene, who has a 50 to 70% chance of having a colon cancer gene. So it's a somatic test, but it also can tell us about someone's germline mutations. So in that family, the medical oncologist was using it for figuring out if chemotherapy would be appropriate, but then it was like, hey, by the way, you have a 70% chance to have a genetic mutation. Go see the genetic counselor. So the patient and the family came to see me, and he was interested in genetic counseling and testing, but he wanted to know for his 2-year-old daughter. So in this case, we talked about the pros and cons of genetic counseling and testing, and how this information can help to confirm whether or not he has Lynch syndrome, hereditary colon cancer. But at this point, we would not do genetic testing for his daughter until about age 18 or 20. Age 18 is the legal age that we can do genetic testing for adult onset cancer conditions such as BRCA, Lynch syndrome, most Cowden syndromes we test later onset. But there are some exceptions to that rule. So for familial polyposis and medullary endocrine neoplasias, we do test children because that's when the cancers can present in childhood. But for Lynch syndrome, for 99% of families, waiting until age 18 or 20 is the standard protocol because medically we're not going to do anything differently for them. So it was a bit of a challenge when we had that conversation about we can test you now, but if your results come back positive, I'm not going to recommend or advocate for testing your 2-year-old daughter because medically we won't do anything differently. So 2 to 3 weeks later, the results came back in, and lo and behold, he was a carrier for an MSH2 mutation linked to Lynch syndrome. And when we talked about the option for testing, the wife was absolutely livid that I wouldn't perform genetic testing, even though her doctor had told me to. Well, a doctor can tell you something to do, or a healthcare provider can tell you to do something, but you don't have to do it if it's not within the ethical or legal realms of things. So I discussed with the doctor about why we're not going to test the 2-year-old daughter, and after informing them about the ethics of this is Lynch syndrome, not FAP, we're not going to do colonoscopies for her until she's 20. He understood the reasoning behind that. So it's constant education for our providers regarding the ethics around genetics. So the mother was upset. She ended up throwing papers in my face. But after she had calmed down, we had discussed that, I understood she was mad. She wasn't mad at me as the provider. She was mad at the situation of her husband having colon cancer at 31 and learning that her daughter is at risk for this. And we also learned that not only is her daughter at risk for Lynch syndrome, her daughter is also at risk for BRCA because the wife also is a BRCA carrier. So it's just coming to a head at that counseling session, and she wasn't taking it out on me, but the whole situation of her frustrations of the genetic situation she's been put in. So fast forward, and this person, the male who has colon cancer at 31, he has a half sisters and half brothers from his father who had passed away. His father had other relationships and had a daughter who my patient is not really in contact with. So she's in her 20s. She's appropriate for genetic testing because she's at risk for colon cancer. She has the same genetic marker. But my patient's not in contact with his sister. They had a feud over $200 and they're not talking at this point. They're on Facebook though. So we talked to the male patient about how we can convey this information to his sister, but it's not my job to tell her that she's at risk for Lynch syndrome. It's not my duty to go and break my patient's confidentiality. Even if he wants me to contact her, that's outside of my scope of practice. But what I can do is give my patient the tools of how do I discuss this information with my family, how do I discuss this with my children, what age is appropriate to discuss this with, but also how do I discuss this with people that don't know that I have cancer or that I haven't talked to in 10, 15 years. So he did reach out to his sister via a letter that we helped him to draft, and she received that information. She discussed it with her doctor, and she came into one of my other clinics for genetic counseling and testing. So the original patient gave us the family history that the father had colon cancer at 41, and that he had colon cancer in his early 30s. But the second patient comes in, who's the sister, comes in and says, oh, by the way, there's all this other family history, and we also have a third stepbrother from a different relationship who doesn't even know about our family history because the parents have decided not to disclose that the father that they think is the biological father is not. It's actually the person who died of colon cancer. So when I think about ethical dilemmas, I think about this family in so many different ways. So now we have a 17-year-old male who's also at risk because he's also the child of the male that had colon cancer at 41. And how do we get this information to that family? So again, it's not in my position to tell somebody what their relatives had. I can't breach that confidentiality. But if a patient brings in, here's my brother's test results that he gave me, here's the family history results that he gave me, if they walk in the door with that information, then I can use that information. But when she asked me, how is my brother doing? How is the chemotherapy that he's going through? I can't share that information. I can't disclose that. But I can say, well, here's based on the information that you provided. So now we've got the sister who has also tested positive for Lynch syndrome, and she has 5 children. She's pregnant with her 6th, and she has decided that 5 is enough and that she needs to terminate this pregnancy. And in the middle of that is when she had contacted the mother of her 17-year-old half-brother, that the original patient who started all this isn't even aware that he has a half-brother. So where do we draw the line? Is it my second patient, who's the female, who knows about the half-brother, is it her job to contact the 17-year-old son? No, that's not her position, but she can contact the parents who can process this information and come up with a plan for what works best for their 17-year-old son. And fortunately, I did not have to see the 17-year-old son. He had to see my colleagues over at MD Anderson, who I helped with this mutual family. And what ended up being was that the parents, so the biological mother of the 17-year-old and the father, who he knows he's not the father, but the son doesn't know that that's not his biological dad, they wanted to fabricate a family history and say, okay, my 17-year-old son's at risk for this family history, but we couldn't do that. We couldn't, fabricate this false family history. So what ended up happening was that the family had come to an agreement after multiple sessions of genetic counseling to, finally tell the son, we know that you think that this is your biological father, but your father had passed away of colon cancer and you're at risk for this genetic condition. So lots of twists and turns here, and this is just one case of many that I have of the complications that we see in genetics. So it's not always easy, but we do work with ethical boards. The 17-year-old did not have testing at 17, but when he turned 18, he wanted to know this information, and he also has the genetic mutation. So all three of those children were found to be carriers. And, you know, that's a lot of psychological conditions, psychological issues can pop up, but what they've all have said was that they're glad that they learned of this information, because rather than dying of colon cancer or uterine cancer, they're eligible for early screening and can prevent it from happening so that they don't have to be dead like their father at age 41. So there's a silver lining to a lot of these cases. You know, some people think of genetics as harmful, or why would you want to know this information? You must make, I have people that say, how is your job easy when you have to tell people bad news all day long, day in, day out? Well, you know, when patients are given the correct information, they have informed consent, they have proper counseling, and they're given the information before they have testing. Well, by the time the results come back around, my patients can tell me what I've already told them, and they understand the results beautifully. Just on Friday, when I was finishing up my clinic for the week so that I can come down and be here on vacation, my patients, I had told two families that they had FAP, and they were actually very relieved of this information that the results came back positive, that there was a deleterious APC mutation. Well, why in the world would someone want to be positive for FAP? That has a near 100% risk of developing colon cancer. Well, in these families, they had already presented with multiple polyposis. They've already had subtotal colectomies or total colectomies. So for them, their results identify that they have an explanation for what caused their polyps or what caused the early onset colon cancer in their family. So now they have a reason. It's nothing they ate, drank, smoked, didn't do. It's their genetics of what they were born with, and they have an answer. And the same thing for the male that I told that he was BRCA1 positive. He had a reason for all the breast and ovarian cancer in his family, and he was concerned about the next generation of when they should have screening or surveillances. So in a nutshell, it's kind of what I do with my day in, day out for genetics. So I think the slides here, they wanted to go over understanding and recognizing the ethical concerns about predictive and prenatal genetic testing. So I gave you some cases on the cancer genetic testing, and so I think those are cases that we can go over as well. And then I think I'll pass it over back to Dr. Pella to cover the ethics of germa and somatic gene therapy, as well as the concerns in interspecies mixing if we get that far. Yes, question about.
I'm just curious, what kind of testing are you doing? Like, what's the difference between the genetic testing that you're doing on specific patients versus like them going and getting like 23andMe, for example, their entire genome? Would you get the same information from the 23andMe, or are you doing like
Yeah, so that's a great question. A consult that I probably get about once per month is, hey, I have this 23andMe test and it's $99. Why should I come see you? And the test is $4,000 to get BRCA testing. I can get, you know, my whole gene sequence, and I only get 2 genes with BRCA. So the quality is completely different. They're looking at a small piece of the DNA here and there when they do the testing at 23andMe. You know, 23andMe is not allowed to do genetic testing. They're not FDA approved. That's all been pulled off the market. And there's a reason for that, is that the testing is not perfect. It's not validated. And they even come out and say that do not use this for medical purposes. But for example, we have, there's known cases where the 23andMe results have indicated that someone has a TP53 deleterious mutation, and go talk to your doctor about it. Well, when we find out that we clinically confirm that by a Sanger sequencing, by a more detailed targeted testing, none of those patients thus far have been confirmed of having that rare genetic condition, because a mutation in TP53 would result in Lee-Fraumeni syndrome, which has a very high risk of cancers, many of which we don't have any consensus or guidelines for screening on. So the technology is different, and it may not be as accurate. I know that 23andMe also does BRCA testing. BRCA was patented up until about 2013 by one company in Salt Lake City called Myriad Genetics. But in 2013, the Supreme Court reversed those rulings, basically. But prior to that, there's 3 specific mutations that we see that are common in the Ashkenazi Jewish ancestry, and that just means Eastern European Jewish. And those 3 specific mutations we can test for. You don't need a patent to do that. So what 23andMe had done was tested for those 3 specific mutations. How I think about our genes is they're like books, they're instructions. They tell our body how to form, how to function. Our cancer genes tell our body how not to develop cancer. So when we do a sequence of the DNA, we're looking at every single page, every single letter. We're making sure all the chapters are there, they're in the right order, they're not upside down. We're also making sure that the books are in the bookshelf properly. That's what a very thorough sequencing would tell us for genetics. With the 3-site testing that 23andMe would do, they would look at 2 pages in BRCA1 and 1 page in BRCA2. And that's what their BRCA testing was. So if you had a mutation on page 500, but they only tested page 270, they're going to miss that. They're going to say it's negative, but you actually do carry a BRCA1 mutation. So there's the differences in the technology. Question?
Can I ask a question?
Yeah.
So when you were talking about the physician who sent a patient to you for genetic testing, and then of course he agreed with your opinion, and can a doctor though decide that despite what the genetic counselor says, he wants to order genetic testing? Can he do it without their approval?
Correct. So anybody can order, anybody that's genetic counselors can order the testing, nurses, physician assistants, physicians can order genetic testing. But at our institution, all the genetic testing is done through a genetic counselor because it's the gold standard. For that family that wanted to test their 2-year-old, I provided some literature for them, things to think about. One of the concerns in that testing minors for adult onset conditions, well, there's a lot of laws that are in place to protect us. So there's the GINA laws, the Genetic Information Non-Discrimination Act, that went into place in 2008 and has not had any inkling of overturns. And that law protects individuals with genetic predispositions that cannot be discriminated against for their health insurance policy and for employment if they work for a company that has 15 or more people at the company. What GINA does not protect people against is for life, long-term care, or disability policies that are not already in place. So if we test a minor, we're pretty much, and they test positive, we're pretty much eliminating their possibilities of ever getting a life, long-term, or disability policy. And we've taken that right away from them to know or not know this information. Because maybe, they don't want to know that they have a genetic mutation. That's someone's right to not know this information as much as it is to know this information. We've also know that when some people did test teenagers for BRCA mutations, BRCA presents in the later 20s, 30s, 40s. The children who were tested without their knowledge or without informed consent would be more rebellious, so they would be less likely to proceed with the mammograms or MRI screenings, whereas those who made the choice of, I want to know this information, I'm ready for this information, were more likely to follow up with the mammograms and MRI screenings that are appropriate. So we know that when it's a patient's choice to know this information, they're more likely to follow up on the clinical care as well. So for that doctor and for that patient that wanted to test their 2-year-old daughter, we had a long discussion about that. The doctor was on board with waiting because he realized that there's 2 different types of hereditary colon cancer, one that presents early onset, one that presents later. And this family has the one that presents relatively later in adulthood. And we offered them the option for a second opinion at 2 of our other institutions in the area to discuss the options for genetic counseling and testing for their child. So I don't know if they followed up with that, but I don't believe that the child has had genetic testing at this point.
Also, can an emancipated minor or mature minor who's not yet 18, can they say, well, I don't care that I'm not going to have problems or I don't need screening until I'm 20. I want to know now. Would you test them if they're emancipated and they demand it?
Yeah, so anybody can tell me what they want me to do, but it's my license, it's my practice, so I don't have to test that person if it's outside the scope of our guidelines or outside the scope of the practice. Now, I have made exceptions where it's medically appropriate. So Lynch syndrome, we think of colon cancer onsetting at age 25 or thereafter, so that's the age thereabouts we start. But in some families with Lynch syndrome, we have documented cases of 13-year-olds with colon cancer, 14-year-olds with colon cancer. So in those families, if we wait until age 20, 25, that's going to be too late to start for colonoscopies. So we do make case-by-case exceptions. So in the family where we have the relative who had colon cancer at 13, we start 5 years prior to that. So testing for minors in that situation, because it's medically appropriate, would be an option that's available. So there are cases and rare exceptions to the rule. But that's all in clinical judgment. So here are some of the objectives that are listed. I'm not sure if I'll be covering them or if your professor will be. But this is regarding the Human Genome Project, how the sequence was completed in 2000. The price of genome testing has come down. We're working towards the $1,000 genome. So here's one of the cases, and I've actually seen a similar case in practice. So we have twins here, and a monozygote pair, which means that they're genetically the same, and they're at risk for Huntington's disease, and one of the twins requests predictive testing. So any of the results, if we have identical twins, any results of one person is going to tell us about the information of the other person, who may not want to know about developing HD or may not want to know about these results. What would you do in that situation where you have identical twins, one result equals the results of the others? Do you do genetic testing, or how would you go about this?
Are the twins of age?
That's a good question. Let's go with yes, they are. Let's go with they're over the age of 18 and they're at an age appropriate for genetic testing, and one of them wants to know about this information and one does not. Or maybe we don't know about the other. Yes.
I was just say yes. I'm going to presume they have independent medical records, and yes, I'll test the one, record it in their chart, and nothing goes in the other's chart because they're independent individuals.
And there's some other comments out there?
Yeah, I was gonna say, the one has the right to get tested, so.
Okay.
Whether or not you tell the twin,
So this, right, and so this is one of those challenges. So would anybody say no that they wouldn't test their patient if they're of age? Okay, that's a correct answer, because if the person wants to know this information legally, they should be able to have access to these results if they're age appropriate. So in this situation, typically with HD, it's recommended to see a psychiatrist prior to genetic testing to come up with a plan of what they would do with that information. So Huntington disease testing in traditional models follows the old school 3 counseling session visits, where you have a pre-test counseling session with the patient to go over the pros and the cons. Then they come back to decide whether or not they want to have genetic testing. If they have testing, then they come back to get the results in person. And the reason for that is because HD has no known medical treatment or cure for it. So testing, even though it's available, a very small percentage of patients, I want to say less than 20% of those who are at risk for HD actually proceed with the testing, because sometimes ignorance is bliss, sometimes knowledge is power. So certainly testing would be appropriate for this person who wants to know this information, but we have to think about how do we protect the other twin of this information. Now, are the twins in good communication? Are they not in good communication? I think that's part of the consent process with the patient, is to help them to understand you're welcome to know this information, but it would be mindful for you to realize that your relative may not want to know this information. So just be mindful of how you process this information. Now, we can't stop them from blasting it on Facebook if they wanted to, or Twitter, that they have Huntington's disease, and then that tells everybody else that their identical twin has it. But usually when I see identical twins, which we have a number of in our practice, most of the time the twins are on board with, if one wants to know the information, so does the other. But we have to be mindful that they're individual persons and that they should be treated as such.
You mentioned that there's a psychological consult, I guess, before testing. That's for any genetic testing, right? Not just Huntington's?
For Huntington's disease, it's recommended that patient does go through the psychological evaluation prior to. That's not necessarily true for other types of genetic testing. That's primarily because there's no known treatment or cure for Huntington's disease, whereas for BRCA, Lynch syndrome, MEN, and prenatal, there's things that you can do actively with that information. For Huntington's disease, my understanding is with the patients the clinic that I work with, is that it's more for them to plan and prepare for the future of what to do for their families if they do have HD, or can they have a weight lifted off their shoulders if they don't have HD. Yep. So these are some things that you guys already brought up. So liberty, we're free individuals to make medical choices for ourselves, so if it's appropriate for a person to know this information, but then also respecting privacy. So what if your patient is the twin that chose to decide to have genetic testing, and you now know that they have HD, and their twin by definition of being identical twin, also has HD, but they don't know this information. Is it in your scope of practice to have to notify that person, that twin that's at risk for this? Is that in your scope of practice to notify their employer or anything? What if this is a dangerous or hazardous situation for that person? Yeah.
In our last class, we talked about like usually, like one person got in trouble because they didn't tell the wife, because the husband got Lyme disease and didn't tell the wife, so then he got sued. So like, if you get sued, you did not tell women, it's not
Yes, I think this would be a safe situation that you would not be obligated to tell the other person that they have Huntington's disease. That twin's likely aware of the information, but it's up to your patient to convey that information to them if they want to know that information or not. I mean, I see this with I can't speak to Huntington's disease, but I can speak to, BRCA and Lynch syndrome, where we have twins and we have that conversation with them first and make that aware to them that if you have genetic testing, whatever your results are is also the results of your twin. And if they're not on the same page, or they don't want to know the information, if one wants to know the information but the other does not, then the person that's having testing is aware that if that person ever changes their mind, that they can convey that information to them later. One of the tricks or other trait that I use is that when we do genetic testing, it's not like NCIS and you get the results like printed off right there in the 5 minutes that they did the testing. It usually takes a good 2 to 3 weeks to get those results back. So when I counsel a patient, we're talking about genetic testing, they don't know the results by the time they leave that room for genetic testing. That's still pending. We don't know if they're positive, negative, or inconclusive. And so during that time period, some people may wish to share this information with their family that, hey, I've had genetic testing. I'm concerned about the family history of X, Y, and Z. I don't know what my results are yet, but when I do get the results in, is this something that you want to know about? That way, those other relatives have that, kind of ball in their court of, yes, please tell me, absolutely, I want to know, or nope, don't talk to me about that ever again. The relatives know that the information's there, and they can always, reconsider that information at a later date. So I really, one of the major points of my job is to help patients not just to manage their genetic syndrome, but also how do I discuss this information with my family, and how do we, respect other people's privacies. It's easy for me, when you see pedigree, there's a lot of squares and circles. I tell my patients it's really easy for me to point at the squares and circles on that page, but I don't know what their relationship is with those other relatives.
So kind of going more on what he said. So let's say you have identical twins, and one of them decides to come in and get tested for familial polyposis, and he comes positive. You said that it has almost 100% chance of developing colon cancer after that. You are not obligated to tell the other twin that he has it, because he will most likely develop cancer as well.
That is correct. I've actually seen that play out in a clinical scenario, not that same scenario, but with familial polyposis. So my duty is to inform the patient that this is a genetic condition, that their relatives have a 50% chance to carry that same genetic mutation, and then it's up to that person to share that information with their relatives. So if that twin develops, the other twin develops colon cancer, it's not on me for not telling them. It would be on me if I didn't tell the first patient that, hey, this is a highly genetic condition, and this affects your other relatives. This affects your children, this affects your siblings, and each of your relatives have a 50% chance to have that same genetic marker. If I didn't tell my patient about that and didn't document that in my notes, then I would be liable for not informing my patient about the genetic risk to their relatives. But it stops there. I'm not liable I don't have to reach out and tell that twin. And we've seen that when I was at South Carolina, there's a very large familial polyposis family up there that we've been following, or my mentor's been following. And the mother did not want to inform her children about the FAP in the family. She did not want to put that burden of information on them. She didn't want to have them go through the colonoscopies. She had a different way of thinking about medicine, and she just didn't want the same life for her children. And so we counseled her that this is a highly genetic condition and that we can do a blood test to confirm whether or not the family members are at risk for this, but it's up to her to share that information. She wanted to keep the information private into her own medical records and did not wish to share it with her family. So even if she brought family with her and they were in the waiting room, I couldn't go out there and tell them, hey, go see a doctor, go talk about FAP. So unfortunately, the daughter actually developed colon cancer at age 18 and passed away at age 19. And that was the mother's choice, to put it in very harsh terms, was she allowed that to happen by not wanting to intervene medically.
Also, usually, I mean, if I wanted my insurance to pay for a colonoscopy, it's gonna be after age 40, I believe, or something like that. Let's say I go through genetic counseling and I get, I get the results where I'm positive for familial bullosis. Would my insurance start paying for colonoscopies earlier?
Yeah, absolutely. So that's one of the main reasons that we use this the genetic testing. So for example, with FAP, we start with colonoscopies as young as age 10 to 15 for the typical classical version, and in late teens for the attenuated version of FAP. And there are many medical guidelines, NCCN, SGO, to name a few, that have specific guidelines on how do we follow families with certain genetic conditions. And many insurance companies follow those guidelines as well. So we actually use this information to help people get coverage of colonoscopies. The one that we use this in most frequently for colonoscopies is for Lynch syndrome. So most polyps take a while to go from a normal colon, a polyp develops, and then that polyp sits there for 5 to 10 years before it turns into a full-blown colon cancer. Well, in somebody that has Lynch syndrome, it goes from nothing to polyp to colon cancer in a much shorter time interval. So it's very key that we identify these individuals so that we can make sure that we're getting them more frequent colonoscopies. With FAP, the polyps still take a while to develop. It's just the number of them that makes the cancer risk so high. But with Lynch syndrome, the turnover rate from precancerous polyp to cancerous polyp is so quick that if we go every 3 to 5 years, that's not going to be good enough. So the average risk, we go age 50, and go every 5 to 10 years, or earlier if there's any polyps or family history. If someone has a family history of colon cancer, we typically start 10 years prior. So if, let's say someone's dad had colon cancer at age 40, then let's start at age 30. But if someone, and we would go every 3 to 5 years based on family history alone. But if someone has a genetic mutation, say FAP or Lynch syndrome, then we start younger. Lynch syndrome, we start around the age of 20 or 25. And we go every 1 to 2 years because of how quickly the colon cancer develops. We've seen patients who had colonoscopies every 3 years, and they developed an advanced colon cancer in that time period, and that's because they had Lynch syndrome and they should have been going every single year. Yep, so we use that with the insurance companies to get coverage. And the same thing for breast MRI screening.
So I think one of the reasons students are asking to clarify the question about to find one identical twin that has a genetic related cancer condition, you have to tell the other one, just because they learned about New Jersey case safety impact and in the 90s, and in that case they sort of rejected the Florida approach, was that if you tell the patient you're discharging your duty to anybody else. It's up to the patient to tell the other people. But New Jersey, although they didn't have to decide this question, so it wasn't holding, it's sort of like a dictum, a throwaway, but New Jersey suggested that might not be enough, and that depending on the specifics of the case, that the provider, in that case the doctor, might have to do something else to warn third parties, to protect third parties. So when you seem pretty categorical that that's not the situation, is that because is the situation different for genetic counselors than it is for physicians?
No, it would be similar. Maybe that I don't practice in New Jersey and we don't have those similar laws. I would say that all of my identical twins that we've seen that have genetic mutations, all of them have been on the same page, that they will both want to know the information, they both don't want to know the information. So unfortunately, I've not been put in that clinical situation. I would disclose it if I were put in that situation. I would actually have the information reviewed by my other genetics colleagues, and I'd have it reviewed by our hospital ethics committee on what the most appropriate legal course of action would be.
So your state won't follow 2024?
Oh, yeah, that's been our experience. And that'd be important as you practice elsewhere to know what your specific scenarios apply. I've got one here and then over there.
In the case of the FAP family with the minor children and the mother that didn't want to disclose, is there any thought to going to like DCF or something like that? I mean, it's almost like child abuse that you're withholding medical care. If the child had cancer and the mother wasn't getting care for the children, they'd be taken away. So it's almost like kind of that same line. Was there any thought of trying to court mandate
Well, there might-
testing?
Yeah, so there's a slight difference there, is that if you have a child with cancer, they're actually presenting with a clinical disease. The child who is at 50% risk for FAP is not presenting with disease. It's just that the mother wasn't, going for colonoscopies or doing the frequency. So when she reached 18 and she was having rectal bleeding, she was referred to get a colonoscopy, and that's when they identified the polyposis. And then she was treated from there based on her FAP. And I'm sure that if she was 17 and she presented with rectal bleeding and needed a colectomy, that she would have been treated. It's just that the mother did not want to know whether or not her children had FAP.
Right, so I'm saying, could you get a court to find out for sure? Because if I understand FAP, like if you have FAP and you're younger than 18,
Mhm.
do you start with colonoscopies in the
yeah, we-
younger population?
We do colonoscopies for the classic version at age 10 to 12. Waiting till age 15 is not unreasonable. And then for the attenuated version, we start around the age of 16, 17, the later teens.
So the 50% chance isn't enough to say it's abusive not to not to have that information?
Good question.
Yeah, just a thought.
Yeah, because it's a 50% risk, and if they decide not to have genetic testing, then the NCCN guidelines say, okay, if you want to forego knowing this information, then at bare minimum, you should still get a colonoscopy to see if you have any polyps. Of course, if there's any polyps there, then that's going to be pretty indicative that that person already has FAP. So maybe the mother also didn't want to know, by doing a colonoscopy, because that would give her the genetic test results as well. Yeah.
If it gets through and he goes through like a psychological review for this, would they need to have like an additional like more psychology than a typical Huntington's disease testing? Just because if he gets the markers and he looks more sad outside of life after that, doesn't that invade the other person's privacy of saying, oh, that's by 40?
So that might be part of the initial psychological evaluations. A traditional HD testing and HD appointment is pretty in-depth, and I'm sure the psychologist would go over that kind of scenario. There, in my experiences, patients who are testing for HD have to write what they would do the day of their results if their results came back positive, and what would they do the day of the results if the results came back negative. So they kind of walk through if this happens, what are you going to do with this information scenarios. And that's before they even decide to have genetic testing. In a very traditional role. Now, that's not how it's always done. HD testing, you don't have to go through that process, but in the very traditional models, that's how it's done. Any other questions about the monozygotic twins case? I think we have a lot of cases there.
Why don't we take a 10-minute break now?
Okay.
Is it a good place?
Sure.
So you know how Greg was asking about like the differences in testing versus the other one? So what was she saying? She was differentiating hers from what he was saying, which was the 23. Yeah. So like what was
She was using one example of one genetic test
that she performed?
Well, she doesn't perform it.
But like when
They order.
Yeah.
The oncologist actually orders it. Like when I worked for oncology, I would fill out a form and get the path and send it to Myriad.
Okay.